I am Dr. Pooja Ramakant, Professor in Endocrine Surgery Department at King George's Medical University, Lucknow, and I shall be talking about the components and genetic basis of Men's syndrome. So the specific learning objectives of this lecture will be, first I shall talk briefly about the history of Men's syndrome, then what are the types of Men 1, Men 2A, 2B, Men 4, Men 5 syndromes, the new ones, then the genetic phenotypic correlation, and then the comparison of all these Men's syndromes to understand the differences and the individual Men's syndrome. So as the name suggests, this multiple endocrine neoplasia, which means that there will be multiple tumors of endocrine origin may happen simultaneously or at different parts. So going to the history, if you see Abraham Lincoln, as the picture demonstrates, he has got hooded eyes, asymmetric jaw, very enlarged bumpy lips, beard and his collar are hiding the thyroid cancer which he had. He had constipation and he had a strong family history where his sons died at young age, sudden deaths in the family. At that time, the Men's syndrome concept was not very clear or very common to people, so it was not founded out. So after his assassination, from the blood stains on his pillow, people did the study, and in his DNA, they found out that he has genetic mutation of MEN2B. So it was identified very late after his death. However, it was proven, and then further generations would have been benefited. Then Steve Jobs, he had pancreatic neuroendocrine tumor and he succumbed to that. If you see all the neuroendocrine tumors when we have anywhere in the body, especially in the pancreas or GI tract, then MEN1 syndrome has to be ruled out. So the significance of these syndromes are they may manifest in certain form of a tumor, and then we have to look for whether the patient has other tumors or not so that we don't miss managing them. So coming to the history of Men's syndrome, in 1968, Steiner et al. Introduced the term multiple endocrine neoplasia, which means, as the name suggests, is a combination of endocrine tumors. In 74, Seymour categorized MEN2 into two different MEN2A and 2B category because they behave very differently. MEN1 is also called as Wermer syndrome, MEN2 as Sippel syndrome, MEN2B as Weidman-Froebus syndrome. Different people found it out that patients of different categories of tumors came together in generations of the families, and then they realized that this is a separate entity. So MEN2 got split into MEN2A and 2B. Men's syndrome encompasses several distinct syndromes featuring tumors of endocrine glands, each behaving very differently. It has an autosomal dominant inheritance, which means if there are four kids in the family, then two will get the syndrome transmitted by genetic mutation. So the significance of these mutations are that once we know, we have to screen the first degree relatives to find it out who else have this and then manage them accordingly. There are prophylactic surgeries based on the codon depending on the mutation positive. Like in MEN1 gene, it's on chromosome 11, short arm of 13. It's a tumor suppressor gene. It encodes menin, which is a 610 amino acid protein. MEN2 has got RET mutation, which means RET is a full form of rearranged during transfection. It's on chromosome 10, short arm on 11. It's a proto-oncogene. So if you see the RET gene, has 21 exons. It belongs to tyrosine kinase family, and MEN2 syndrome has missense mutation, base substitution or deletions. So if you see in this diagram, if you see like patients who have 609, 600, 611, 618, most common is 634 codon, if they are positive, then that is MEN2A or familial MTCs. Then in 700s like 768, 790, 804, that is familial MTC. And then in 900, 918, it's meant to be. So 600 ones are lesser risk, less aggressive compared to 918. So as the codon number increases, the aggressiveness of the disease also increases. So once we know the codon, so we can understand and predict the disease biology also. So all these genetic mutations have got a clinical relevance. Coming to MEN1 syndrome, if you see how do we define MEN1 syndrome, it means that It's a benign patient may have benign or malignant tumors. There are three major tumors out of which at least two should be present in the patient. Or a patient has got one gland tumor disease. Along with that, one family member has got first degree relative has also got Men-1 syndrome. So that's how we define Men-1 syndrome. 75% patients may have one or more tumors by 20 years of age. 100% will manifest by 50 years of age. Coming to the components, the three most common major criteria are parathyroid, pancreas, and pituitary. Parathyroids, mostly patients have got hyperplasia. It's 95 to 100% times manifested. Hyperplasia means that it's a disease of more than one gland. So if it is adenoma, it may be confined to one gland, but in men, one, we have to dissect more than one gland, like three or three and a half. So that is the significance of having hyperplasia instead of adenoma. Coming to pancreas, 30 to 40% time it's affected. Most commonly, it's gastrinomas, 20 to 60%, followed by insulinomas, VIPomas, or glucagonomas. So all these tumors, neuroendocrine tumors, may produce different hormones, and then the clinical manifestations may be different according to which the patient manifests. Like gastrinomas will secrete more gastrin, patient will have gastritis. Insulinomas will cause less sugars, so patients will have features of neuroglycopenia. VIPomas will manifest accordingly. Glucagonomas will have diabetes, skin reactions, like that. Pituitary tumors manifest in 30 to 40% patients. Most commonly is prolactinomas, 20%, followed by somatostratinomas. Other tumors like adrenocortical tumors, thymic neuroendocrine tumors, lipomas all over the body, angiofibromas, or collagenomas all over the body are also part of the minor criteria of Men-1 syndrome. Coming to Men-2, it is associated with medullary thyroid cancer with other neuroendocrine diseases also. Men-2A has got four subvariants. One is classical Men-2A. Second is Men-2A with cutaneous lichen amyloidosis, where the patient also has got a skin lesion. Third is Men-2A with Hirschsprung's disease, mostly in children. Fourth is familial MTC, where only MTC's medullary thyroid cancers are there. So MTCs in at least four family members across at least two or more generations should be there, and no other pheochromocytoma or parathyroid disease. Then Men2B is another variant of Men2. Coming to Men2A, the components are medullary thyroid cancer, up to 100% of the patients will have pheochromocytomas, and 50%, primary hyperparathyroidism, mostly adenomas in parathyroid glands, in up to 50%. Coming to cutaneous lichen amyloidosis variant, this is a skin lesion which is present in mostly in the scapular lesion, dermatomes T2 to T6. It causes intense itching and it improves on sun exposure. There is hyperpigmentation due to repeated scratching, and it is associated with the codon 634 mutation. So if somebody has got this, you can directly hit codon 634 mutation, and if it is positive, you label the patient as Men2A with cutaneous lichen amyloidosis variant. Coming to Men2A, Hirschsprung's disease, which is usually present shortly after birth in children. Late onset is rarely possible. It is associated with exon 10 mutations on like 620, 618, 611. Then familial MTCs have RET mutations. There's only medullary thyroid cancers running in the families. No other pheochromocytoma or parathyroid lesions are running in the family. Coming to Men2B, the components are, if you remember Abraham Lincoln, you remember that figure, you will realize medullary thyroid cancers in 100%, pheochromocytomas in 100%, mucosal neuromas, megacolon, marfanoid body habitus, and medullated corneal nerve fibers. There's corneal nerve thickening which the ophthalmologist can see, and if you see all these components, you label the patient as having Men2B syndrome. It is on RET mutation on 918 codon or 883. Most commonly, it is 918. Coming to genotype, genotype means there's a set of genes or alleles which is responsible for a particular trait. Phenotype is a physical expression of that genotype. So in Men1, unfortunately, there is no genotype-phenotype correlation, so difficult to comment on that. But in Men2, As we have seen the patient's pictures, there is a strong genotype-phenotype correlation. Basis of targeted gene testing is if somebody has got CLA, like I showed you, you can directly hit the codon 634 mutation and confirm it. So based on this genetic mutation, you can do a codon directed surgery. That is prophylactic thyroidectomy in 918 mutation before 1 year of age in infant. So it depends on the risk stratification, that is how risk it is. The highest risk needs the earliest possible surgery. So this is called as codon oriented prophylactic surgery, COPS as an acronym. In this, you can save the patient before the cancer develops. Coming to MEN4, which has a recent variation of MEN syndrome, it's a phenotype of MEN1 but without menin gene component. So the mutation here is on chromosome 12p of 13. It is CDKN1B gene and codes protein P27 KIP1 protein. It's a tumor suppressor gene. It is also autosomal dominant. All these are autosomal dominant. The components are primary hyperparathyroidism up to 90% of the patients, pituitary adenomas like acromegaly, it's a growth hormone tumor, 10%, Cushing's disease, then pancreas up to 25%, having in the form of gastrinomas or non-functional neuroendocrine tumors. Other tumors like renal cell, reproductive organ tumors, papillary thyroid cancer. So here you see medullary thyroid cancer is not there. It is the papillary thyroid cancer. Then meningiomas, colon carcinomas. Then there can be association with autoimmune diseases like Crohn's disease, myasthenia gravis. So if somebody has got acromegaly with papillary thyroid cancer, so then like this, if you suspect that, then you have to rule out other components of this MEN4 and then label the patient accordingly. So the importance, clinical relevance of this is if you pick up one tumor, you don't miss out the other components which may manifest simultaneously or after some time. Coming to MEN5, which has been the recent one proposed, it is constituted by MAX gene and the components are pheochromocytoma, neuroblastoma, ganglioneuromas, pituitary tumors like acromegaly, prolactinomas, primary hyperparathyroidism, pulmonary adenocarcinomas or chondrosarcomas. So when these combination of rare tumors happen, then that is MEN5. So you see here medullary thyroid cancer is also not there. So if you see this diagram, you can represent clearly and understand like MEN1 syndrome, it is parathyroid, pituitary and pancreas. So pituitary adenomas here, then in the neck parathyroid, and there are four because it is mostly hyperplasia. Then there can be insulinomas in the pancreas or gastrinomas in the duodenum or in the pancreas. MEN2A, simple syndrome, got parathyroid, adenomas, then medullary thyroid cancers, then it has got pheochromocytomas. MEN2B, you see in the tongue, the mucosal neuromas, marfanoid habitus, very tall figure, and then ganglioneuromas may happen. So all these MEN2 has got a very strong genotype-phenotype correlation. So finally, I shall be comparing the various MEN syndromes for clarification of each components of these variants. So MEN1 has got parathyroid hyperplasias or adenomas in 90%, pituitary adenomas in up to 30 to 40% in the form of prolactinomas or somatostatinomas, then pancreatic neuroendocrine tumors in 30 to 70%, which constitutes gastrinomas, insulinomas, non-functional neuroendocrine tumors, then bronchial and thymic carcinoids, which are the most common cause of death in these patients. So thymus has to be removed if you are doing parathyroid surgeries. Then adrenal tumors like adenomas, carcinomas, pheochromocytomas. Then in the skin, there can be lipomas, collagenomas, angiofibromas, and meningiomas in the brain. So if you see patient with lot of collagenomas in the skin hanging around and any other tumor, then you have to look for MEN1 syndrome. Coming to MEN2A, which is constituted by medullary thyroid cancers in 90% to 100%, pheochromocytomas in 50%, parathyroid hyperplasia adenoma in 20 to 30%, then cutaneous lichen amyloidosis and Hirschsprungs are two different variants of MEN2A. MEN2B has got medullary thyroid cancer in 90%, pheochromocytomas in 40 to 50%, marfanoid body habitus, skeletal abnormalities, mucosal neuromas, Medullated corneal nerve fiber thickenings are there, then megacolon. So patients will have clinical manifestations depending on the disease which they have. Then men 4 will have parathyroid hyperplasia or adenomas, pituitary adenomas, adrenal tumors, renal tumors, genitourinary tumors, then pancreatic, gastric, bronchial, and neuroendocrine tumors. So if you see each men syndrome, each variant like men 1, men 2A, 2B, men 4 or men 5, they have got different sets of tumors involved. So the concept is if you have picked up and diagnosed the patient like men 4, then you have to rule out all other tumors, and if it is not present, you have to look like if somebody has got tumor by 20 years of age, you may manage that and then keep the patient in lifelong follow-up so that the other tumor, if it manifests by 30 years of age, you may pick up them before they in that very initial stage or before even if that has happened, and then manage the patient prophylactically, or you can pick up at the earliest stage. So that helps in prognosticating and improving the quality of life of the patient. So men's syndromes are very important because we should not miss. Plus, they may have bilateral adrenal masses. So we should not be just confined with one single large mass and may miss out the smaller tumor which may be in the other adrenal gland, because 50% times they may have bilateral tumors. So these are the references which I have used. You may, if you want to go in depth, you may read more about the molecular part. I have not covered the clinical aspect. I have just covered the clinical relevance of these genetic mutant basis of Men's syndrome. These are the other extra references or sources you can read. And it's very interesting to read about Men's syndrome. I hope you got benefited by this. So with this, I thank you and I hope that you had a great learning time. Thank you.